Hi everyone, it's Heather Augustyniak. Today we're presenting on an important topic with the Life After Cancer Patient Education Series, Genetic Testing After Cancer, Why Does It Matter? We're privileged to have Katie Drum, one of our genetic counselors here at Baptist MD Anderson, to present today. I'll let her introduce herself and get the presentation started. Thank you.
Thank you, Heather. Like she said, my name is Katie Drum, and I am one of the genetic counselors here at Baptist MD Anderson. I have been with the team for about a year and a half now. I graduated with my master's in genetic counseling from the University of Maryland School of Medicine up in Baltimore. Prior to that, was planning on being a dolphin trainer, but through some wonderful situations and circumstances, learned about genetic counseling and genetic testing and realized just how important and interesting it is. And so I am so excited to be able to be here today to talk about genetic testing, specifically when we're thinking about after a diagnosis of cancer. So with that, I will go ahead and share my screen. Again, genetic testing after cancer. We want to talk about why it matters. I do not have any conflicts of interest to disclose. And of note, a lot of the images and visual aids I'll be sharing today are provided by Myriad Genetic Testing Lab. Hopefully, by the end of this presentation, we will have addressed and answered a few overarching questions. The first of which is, what is genetic testing and why do we do it? How does it work? What can we look for? What can results mean for a person? Why would we do it? What would make us suspicious for a hereditary cancer predisposition? We want to talk about what about genetic testing for people who may not have qualified for that genetic testing at the time of their diagnosis in the past? What about people who have already had some genetic testing done? What does it mean for them? And then lastly, why does this testing matter for myself or for my relatives if I no longer have cancer? So hopefully we will have addressed all of those by the end of this. To start, I wanted to share this data from a study back in 2017 that was looking at why patients don't do genetic testing. What we can see is that while cost can be a barrier for some people, for most individuals, the reason they didn't do genetic testing in the past was either they didn't want it or their doctor just didn't recommend it to begin with. Our doctors have a lot to do. All of our providers have a lot of responsibilities, and genetics can be a lot to keep up with. The field is constantly changing and evolving, and that can make it hard to stay up to date with the specific criteria and recommendations. So it's important to keep this information in mind when a person thinks about genetic testing, and maybe their doctor didn't bring it up, but it could still be something that's valuable to them. It is helpful, I think, to start with an introduction to cancer genetics. And while we're going to focus on cancer genetic testing today, we want to remember that genetic testing is done in a lot of different contexts, and there are a lot of different types of genetic testing available. There is prenatal genetic testing and pediatric. There can be genetic testing for cardiac conditions and neurological conditions. Genetic testing in general is becoming a lot more common in a lot of different healthcare fields, especially as we're really focusing, a lot of centers are focusing more on precision medicine. When we think about cancer genetics, we want to put this information into context when we're thinking about various causes of cancer. So this information can sometimes be surprising for people to learn, but in reality, only a small percentage of cancers are actually truly hereditary or inherited. In fact, most cancers are not even running in a family. Most of the time when a person's diagnosed with cancer, it's considered sporadic, meaning it happens by chance. Now, there are a lot of factors that can influence a person's chances or risks of getting cancer. Some of those factors we have little to no control over. For example, whether we're a man or a woman. Men are most likely going to be at much lower risk to get uterine or ovarian cancer, while women are going to be at a lower risk for prostate or testicular cancer. Our age is a big risk factor. The older a person gets, the more likely a cancer is to occur, the more opportunities there are for that to happen. Hormonal factors can come into play when we think about cancer risk. Then we've got all of the outside factors. We've got our environment and exposures like sun and radiation and chemicals. We've got our lifestyle and habits like diet, exercise, smoking, drinking, stress, products we use. All of that to say, in most cases, when a person's diagnosed with cancer, we can't necessarily narrow it down and pinpoint one specific cause. It's some combination of factors. Now, when we look at the other two categories, hereditary and familial cancers, in both of those cases, we see cancers running in a family. The difference is with hereditary cancers, we've identified the cause. Familial cancers are where we see the same type of cancer clustering together in a family. Maybe we see multiple people with breast cancer or multiple people with colon cancer, but we can't identify what's causing it. Maybe a person does genetic testing and it comes back negative. In those cases, it could be that these cancers are unrelated, or it could be that there is something running in the family. We just can't test for it at this time. It could be as simple as shared environment or shared exposures, or it could be something biological. When we think about hereditary, we're thinking about a whole gene not working, but people can have smaller genetic changes that we don't really test for at this time, but those can be shared by family members. There can be hormonal factors shared by family members. There's also genes we don't know about. So just because a person has cancer running in their family, it doesn't necessarily mean it's due to a hereditary cause. But we do know that about 5 to 10% of cancers do have one of those hereditary or inherited causes. And that's when someone's born with a harmful change or a mutation in one of their cancer genes, which we all have those genes and they're meant to protect us against cancer. But if there's a mutation in that gene, it's no longer working. And so our risk for certain cancers can be increased. There are, in general, some red flags that make us more suspicious for a hereditary predisposition, and that would include things like cancers diagnosed at a young age, rare cancers, multiples, either multiple separate cancers in the same person or multiple family members or multiple generations. So there are just some general red flags that we'll discuss in a little more detail later on. But the point of all of this is hereditary cancers only account for a small portion of cancers. What we're looking at here is actually a neat model that was put together from the University of California, San Francisco, looking at all the different factors that can influence a woman's risk of breast cancer. And as we can see, there's a lot going on. There are a lot of risk factors interacting with each other and with breast cancer incidence directly. The takeaway here is not necessarily to be overwhelmed by how many things are going on, but to point out, if we look at on the right-hand side, there's a thick yellow arrow saying high penetrance genes. That is the hereditary component of cancer. And it is a big arrow, but it's only one arrow. It's only one component or one piece of the puzzle when we think about breast cancer risk. There's a lot going on. So it's important for everyone to remember that genetics isn't the only thing going on and the only important factor. There are a lot of other things to be aware of. That being said, let's dive a little more into that genetics arrow. How does genetic testing work? It's the question of the day. So I think it's helpful to review the basics. A lot of times for people, it's been a little while since they've had to think about their basic genetics concepts. But to keep things simple enough, we know that our DNA or our genetics are the instructions for how our bodies function. They are what make us us. Our DNA is organized into the chromosomes. Genes live on the chromosomes, and genes each have very specific jobs and contain the instructions to make the proteins to do those jobs. So our DNA is sort of like a big instruction manual or encyclopedia or book, and you can think of the genes as the chapters in those books. Now, some genes might help determine a person's hair or eye color. Some genes might help our bones grow and develop when we are a fetus or when we're children. And then some genes help prevent cancer. As humans, we have about 20,000 genes, and as much as we know, there's still more to learn. There are still a lot of genes that we know are there, but we haven't actually figured out what they're doing. So we are still learning, but we do know that there are at least 100 or so genes whose jobs involve protecting us against cancer. Just like the chapters in a book, all of our genes are spelled out very specifically, and we want them spelled correctly so that the instructions work, they make the correct healthy protein, and they do their job. Now, there's always going to be variation in how our genes are spelled, and that's normal. That's what makes us all different and unique people. Most of that variation, though, is totally harmless and might change how things look, but it doesn't actually impact the gene's function. So one way to think about it is maybe somewhere in a gene, it's supposed to spell the word gray. And maybe in most people, it's spelled G-R-A-Y, but in some people, it's spelled G-R-E-Y. Looks a little different, but it's still gray. But what if instead in that gene, it says the word G-R-X-Y? Well, now we don't have gray anymore. That's what a mutation is. It's a harmful spelling change. So the wrong letter, missing letter, extra letters that damage that gene. So the instructions no longer read through. We kind of hit a roadblock. We're no longer making the correct protein, and that gene is no longer doing its job. These mutations can occur throughout our lives, and when they're occurring that way, they're going to be in random cells throughout our body. And again, that's a normal process. That's just part of living and being a human. People get mutations in their genes and their cells. However, mutations can also be inherited, meaning it was in the egg cell or sperm cell that made a person. And if that's the case, that means that mutation is going to exist in every single cell in your body. So those are what we're focusing on with genetic testing. We're looking at inherited changes that would exist in all of a person's cells. We know that ultimately mutations are what cause cancer. Cancer cells are defined as having damaged DNA. Our cancer genes, their jobs are to help repair DNA damage. So if one of those cancer genes isn't working anymore, it's not able to repair that damage, and damage can accumulate and lead to a cancer occurring. If a person is born with already one copy of those cancer repairing genes not working in every cell in their body, their risk is going to be increased for cancers. So how are genes inherited? This part's pretty simple and hopefully isn't a surprise to anyone. We know that we get half of our genes from our mother and half from our father. So for most of our genes, there are 2 copies in every cell, one coming from each parent. Here we can see how genes can be inherited and the different combinations that can exist. So coming from the mother, we've got the dark pink and the light pink. Coming from the father, we've got the dark blue and the light blue. And there's 4 combinations of how things can be passed on and inherited. So what I do want to point out is unless someone is going through the complex process of IVF and doing testing that way, we have no control over which genes we're passing on. We can't really pick and choose if we're doing things naturally. So let's say the dark pink copy of the gene has a mutation. We'll assume the light pink and both blue copies of the genes are all working correctly. But the mother, the woman on the left, inherited a mutation, meaning that one copy of that gene in every cell in her body isn't working and only one copy is working. So we can kind of think about it like she only has one shield protecting her against cancer instead of 2. Now, that one working copy of the gene, that one shield, may theoretically be enough to protect her, and she may be able to live her whole life and never get cancer, but her risk is going to be higher because we said mutations can happen throughout our life. And if we only start with one working copy, one shield instead of 2, it takes less of those outside factors and acquired mutations for a cancer to occur. Now, the risk is not 100%. The type of cancer and level of risk just depends on which gene has the mutation. But we do know that whenever there's one of these inherited mutations in a cancer gene, there is going to be some increased risk. We also know that whenever someone has one of these inherited mutations, every time they have a child, it's a 50-50 chance whether they pass on the working copy of the gene or the mutation. And so each child is going to be at 50% risk to share one of those genes or one of those mutations. When we know there's a mutation in the family, we do recommend testing family members. If someone has a mutation, we assume they inherited it from their mother or father, which means siblings and other family members could be at risk as well. So we want to share that information with relatives to have them tested. The benefit, though, is that the benefit of identifying a mutation is we know exactly what to look for in relatives. It's kind of like a needle in a haystack. When we first test someone, we're looking for a needle that may or may not even be there. But once we find that needle in that haystack, we know exactly where to look in relatives' haystacks to see, do they have the needle or not? Do we need to adjust how they're being managed, and are their children now at risk? Or did they not inherit that mutation and we get to take away some cancer risk for them? Also of note, we want to remember that these mutations can occur in and be passed on by both males and females. So if we think about something like a breast cancer gene, that could be passed on by men, and prostate cancer genes could be passed on by women as well. And there are cancer risks for both men and women with a lot of these genes. We'll talk about that more in a little bit, though. So now that we've talked through kind of the logistics of genetic testing, let's try to answer some other questions. What if I did not qualify for genetic testing in the past, back when I was diagnosed? Well, criteria and guidelines are continuously changing and updating. We are learning more and more every day in the world of genetics and genetic testing. And because of that, the information we have is going to be evolving on a routine basis. So maybe in the past you did not qualify for genetic testing back when you were diagnosed, but maybe since then there could have been changes to your personal or family history, or maybe those things haven't changed, but the criteria themselves changed, and now you do meet that criteria for genetic testing. Kind of thinking about some common referral indications for cancer genetic testing. We look for, like we said earlier, young cancers. Anytime breast cancer is diagnosed, particularly before age 45, but even at or below age 50. We might look for colon or uterine cancer diagnosed before age 50. We look for rare cancers like ovarian and pancreatic cancer, or maybe men with breast cancer, things that just aren't as common in the general population, but can be more common with these predispositions. We look for multiple cancers in the same person, especially if they're non-environmental cancers or non-exposure related cancers. Then we look for family histories of maybe multiple people with the same type of cancer or certain combinations. We look for Ashkenazi Jewish ancestry, especially if there's breast or ovarian cancer in that family. And of course, if there's a known genetic mutation. So to think about how things have changed, the types of cancers and ages and combinations have updated over time. For example, it used to be criteria if there were 3 or more diagnoses of breast cancer in a family, but now it can be a combination of 3 or more breast or prostate cancers, as well as whenever there's someone with ovarian or pancreatic cancer. So we've also added in metastatic prostate cancer as a criteria. Things are continuously updated. And this is also not a comprehensive list by any means. So when in doubt, ask your doctor. Even if you've talked about genetic testing in the past and it wasn't necessarily recommended, it never hurts to ask now. You can also always reach out to a genetic counselor or another genetics professional to see if you meet that criteria now. What if I already had some genetic testing back when I was diagnosed? Which is a really good question to ask. Technology has improved and we can test for more now. First of all, how well we can test genes has gotten better. I like to think of genetic testing kind of as a fancy spell check. We are looking through a person's genes to see, were you born with all of your cancer genes spelled correctly, or were you born with a spelling mistake that predisposed you? In the past, we've been able to do that testing, but now with the technology that we use, we can read through much better. It's kind of like spell checking every single letter in that book versus just doing a kind of skim read in the past. So because it's gotten better, it's possible that maybe someone had genetic testing in the past and it came back negative, But now we look and there actually is a mutation in one of those genes that we just couldn't detect before. It's rare, but that does sometimes happen. Second of all, and more importantly, we know about a lot more genes now. We've already said we're constantly learning, so we've discovered a lot of new genes in the past 5 to 10 years. Here we're looking at cancer risks associated with the BRCA genes, or BRCA1 and BRCA2. Now, most likely, if someone had breast cancer in the past and they had genetic testing, it was going to be BRCA testing, and especially if it was prior to about 5 to 10 years ago. These were the first breast cancer genes we discovered. We have been testing them the longest, but we are constantly learning more. The risks associated with these genes have adjusted over time. So on another note, if you've been tested and tested positive for a gene in the past, it never hurts to follow up and check in with your providers to see if management recommendations have changed. I also want to highlight Lynch syndrome, which is the most common hereditary explanation for colon cancer and uterine cancer, as well as you can see other types. In the past, if someone had colon or maybe uterine cancer, they would have been tested for Lynch syndrome because those were the most common explanations. But we can see here, there are a lot more genes that we've discovered that are associated with breast cancer besides just BRCA1 and BRCA2. I also want to point out, again, these risk ranges are constantly being updated as we learn more. But what we want to take away from this is that testing BRCA1 and 2 is no longer sufficient when we're thinking about hereditary explanations for breast cancer. Similarly, there are a lot of other genes associated with inherited colon cancer. So Lynch syndrome testing is no longer considered sufficient because there could be any number of other explanations. Here we can see examples of expanded panels based on the type of cancer. So maybe if someone had a personal or family history of breast cancer, they could be tested for the panel of genes on the left. We can again see that all of these genes are going to be associated with multiple types of cancer, but we can kind of target that testing based on the type of cancer that's suspicious in the family. Or if someone had colorectal cancer in their personal or family history, we could test a colon cancer panel as shown on the right. There are genetic testing panels that exist for breast cancer, colorectal, gynecologic cancers, even thyroid cancer panels or melanoma panels. There are a lot of kind of targeted tests out there that exist based on the type of cancer. Beyond that, though, there are large expanded panels. This chart here is from a lab called Invitae, and it's showing the genes on their common hereditary cancers panel. There's 47 genes, and that's not even all of the genes that can be tested by this lab. Remember, there are a lot of genes and a lot of cancer risks out there. We can have genes associated with breast or ovarian or colon cancer, as well as genitourinary cancers like kidney or bladder. We can have brain cancers or prostate cancer or melanoma that can all have a hereditary link to them. It's important to keep in mind that we are still learning, and some genes might be considered newer in the sense that we haven't been testing them as long. So we may still be learning about the specific risks and recommendations. Our goal with genetic testing is early detection and prevention. And so we're going to have management guidelines for all of these genes. But if we only know that the risk for a certain cancer is increased, we don't know exactly how high, then those guidelines and recommendations might not be hard set. They might not be super clear. It's just information to have. It is important, though, to know your family history, because if you're considering genetic testing, you want to make sure you're being tested for any relevant genes. Just a quick note about how genetic test results can come back. When a person does genetic testing, their results could be positive or negative, or kind of somewhere in between. If a genetic test result is negative, it's reassuring that all the genes that were tested are working in that person, which means they could only pass on working copies to their children. It means we don't have an explanation for their history or their family history, but it doesn't mean no risk. Everyone has risk for cancers, and remember, we can have familial cancer risk. So a negative result is reassuring that a person's history is not hereditary as far as we can tell, but it doesn't completely answer the question all of the time. On the opposite end of the spectrum, a person's testing could come back positive, and what it means for them really depends on which gene has the mutation. So in those cases, it's important for those individuals to talk to their healthcare providers and learn exactly what risks they have and what's recommended for them, as well as how to share that information with family members so that they can be tested if indicated. Now, in the middle, we have a result called a variant of uncertain significance, or a VUS. It sounds a lot more complicated than it is. But if we remember, we're still learning when it comes to genetic testing. And sometimes when a person does testing, the lab can find a spelling change in one of their genes that they just can't quite interpret yet. Maybe we haven't seen that specific change in enough people yet to know, is it damaging the gene and increasing risk of cancer, or is it just normal benign GRAY, GREY variation? If we get these VUS results, we typically ignore them and wait for the lab to learn more, because eventually they'll be able to get the information they need by testing more individuals, and they'll reclassify those results as a positive or negative. And about 9 times out of 10, if not more, these VUSs get downgraded to negative results over time, but it is something to be aware of. Of note, repeat testing for an individual is not needed if they have a VUS. We know how the gene is spelled in them. We just need to figure out a little more about what it means. But these are just some examples of how a person's genetic testing could come back. So what about the cost of genetic testing? Well, it's becoming much more affordable than it used to be. Just to quickly look at this chart is showing the cost of sequencing the whole human genome, basically looking at all of a person's DNA. That's not the sort of testing we typically order in cancer genetics, but this is a really good illustration of the cost. This information comes from the NIH National Human Genome Research Institute. And we can see that back in 2001, it cost what I believe $100 million. Now it's costing less than $1,000, which is pretty incredible that our technology has improved so much that the cost of actually doing this testing has gone down. But what will it cost you as an individual, right? First of all, there are several ways a person can go about paying for genetic testing. There's the insurance route, and a lot of insurance plans will include genetic testing as a covered benefit, although specific costs are going to depend on each specific plan. There are also options for self-pay. Well, actually, going back to insurance for just a second, many plans will actually include genetic testing as a preventative benefit if a person has not had cancer yet. But there's the self-pay option as well. So maybe someone doesn't meet the specific national guidelines or criteria, or maybe they have a really high deductible. A lot of labs are offering patient pay or self-pay options that could be as low as $250 or even less, which is still not insignificant, but is much lower than genetic testing costs in the past. There are sponsored programs that some labs will offer based on the type of cancer a person had. And then lastly, some labs will offer free genetic testing for family members when a positive result is identified in an individual, which is really helpful. The question people have a lot of the time, though, is, can this information be used against me when we're thinking about insurance and costs? And that may have been a barrier to individuals in the past, the fear of insurance discrimination, but there is some good news. We have a federal law in place called GINA, the Genetic Information Non-Discrimination Act. This law prevents employers and health insurance from discriminating based on a person's genetic testing results. One limitation, though, is that this law does not apply to active duty military personnel. It also, on a federal level, does not apply to life insurance, long-term care, or disability insurance. However, even then, there are still some caveats and loopholes. Number one, most of those insurance companies don't actually ask about genetic testing. Number two, any existing policies a person already has are going to be safe. It just would apply to getting new or future policies. And lastly, Florida is actually the first state to do this. We passed a law about a year ago that essentially extended those GINA protections to the other insurances as well. So to our knowledge, in the state of Florida, none of those insurances can discriminate based on genetic testing. And we're really hoping more states will follow suit there. We do want to take a moment to remind everyone, this information is complicated and complex, and genetic counselors are here to help. We want to help make sense of everything and how this information could apply to you specifically. I'm not going to go through all of this information, but these are just some of the topics that, or some of the components that would be included in a genetic counseling appointment that a person might have to talk about genetic testing. We would go through a risk assessment and figure out what's really suspicious in the family. We talk through genetic testing. Who should we be testing? What testing should we order? What genes? What are the benefits and what are the risks? What concerns does that person have about cost or insurance? And then lastly, we're not just genetic educators, we're genetic counselors. So we're going to address the psychosocial concerns. This information can be heavy to learn. And so we want to help a person think through, how would they feel based on different results? What would they want to do? Is this a good time? All of those considerations that maybe a person hadn't thought through before. So to kind of get to the crux of matters, why is genetic testing important for a person or for their relatives? Well, we already know that genetic testing can be important information to have when a person is diagnosed with cancer. We know it can help guide management through either treatment options or prevention. With treatments, we know that some cancers are going to respond better to certain treatments given particular genetic changes that person has. We also know that there's the prevention aspect. Maybe knowledge of increased risks for a future cancer might change how someone decides to manage their current cancer or what surgery they decide on, for example. But what about after a diagnosis? Well, it's just as important, if not even more so, beyond a diagnosis. Genetic testing can be helpful for people who have survived cancer, as well as people who have never had cancer to begin with, because remember, our goals are to detect early or to prevent. From an early detection standpoint, maybe we begin screening at a younger age. If a person has increased risk of breast cancer, we might start breast MRIs as early as their mid-20s and mammograms as early as 30, or maybe we start their colonoscopies in a person's 20s. We might screen more frequently. Maybe we do a colonoscopy every 1 to 2 years, or we have breast screening twice a year. Maybe we add in additional screenings like imaging or exams. And then there's the prevention options. Sometimes there can be preventative surgeries, like maybe a woman considers a bilateral mastectomy to try to prevent a breast cancer from happening, or has a hysterectomy and has her ovaries removed to prevent those cancers. Sometimes there can be medications that are given to reduce a person's risk. There's a chemoprevention medication called tamoxifen that can be given to women who have increased risk of breast cancer to try to prevent that. We can modify our lifestyle and our habits to maybe not decrease our starting risk, but maybe prevent adding additional risk. So maybe someone avoids hormone replacement or adjusts their diet. If nothing else, we can simply be aware of our risks and know what to be on the lookout for. Just knowing that a person's at increased risk can really be helpful in thinking about symptom awareness and maybe taking some health concerns more seriously. So why does genetic testing matter? Well, at Baptist MD Anderson, our kind of slogan is making cancer history. And we really think that with genetic testing, that could be a possibility. If we know ahead of time that someone's got increased risk, we can really stay on top of that risk and adjust their management to detect things much earlier when the prognosis is much better, or prevent those cancers from even happening in the first place. So with that, I would love to take any questions, and people are always welcome to reach out to our department.
Thank you, Katie. I have a few questions that came through. One is actually a question that I get quite often, and that's related to 23andMe and Ancestry. Do you have any comments based on that?
Yes, and that's a question that we get a lot as genetic counselors as well. direct-to-consumer testing is becoming a lot more popular these days, but the clinical testing that's going to be ordered by a doctor or a genetics professional is different in the sense that it's going to be much more comprehensive. With places like 23andMe and Ancestry, they can be great from a recreational standpoint, but when it comes to the actual medical testing part, they're not going to be nearly as thorough. For example, with 23andMe and BRCA testing, they're looking for 3 specific BRCA mutations that are much more common in individuals with Ashkenazi Jewish ancestry, but there are thousands of BRCA mutations that can exist. So if a person had negative BRCA testing through 23andMe, we really only ruled out 3 mutations out of possibly 3,000 or 4,000. We also look at more genes when we do clinical testing and really make it relevant to what's specifically in a person in their family history. If a person ever does have a BRCA mutation or something like that come up with Ancestry or 23andMe testing, it's also recommended to follow up that testing with clinical medical-based genetic testing just to confirm.
And the last question we have is about patients who are adopted or they don't know their family history so often. Previous generations really didn't talk about their medical conditions. What are the recommendations for those folks?
Another great question that we get a lot. The nice thing is that genetic testing is becoming more accessible and more affordable. So even if a person doesn't necessarily meet the specific criteria for insurance to cover testing because they don't know that information, the labs have that self-pay option of potentially $250, if not less. So anytime a person is interested in genetic testing, it's something they should ask about because there are options there. And as long as they understand the testing that's being done and the benefits and the limitations, it's something that should be available for them.
Awesome. I can't thank you enough. I know that this will help many patients. I have these discussions every day in clinic. So hopefully not only the patients that are online, but those that can refer later. So thank you. And I hope everyone has a good day. Bye.
Thank you.